The World Health Organization maintains a list of the most dangerous diseases on Earth. Ebola, Marburg, Nipah, Lassa Fever, MERS, Crimean Congo hemorrhagic fever. Every disease on that list has killed people. Every disease on that list has a name, a pathogen, a known mechanism of infection. And then at the bottom of the list, there is a blank space. No name, no pathogen, no known mechanism, just a placeholder. They call it Disease X. Scientists are actively building vaccines for it right now. Governments have signed international treaties to respond to it. A coalition. Disease X is not a disease. It is a concept. A placeholder name adopted by the WHO in February 2018 when they added it to their official priority list of pathogens requiring emergency research and development. The reasoning behind it is straightforward on the surface. The next major pandemic will almost certainly be caused by a pathogen we haven't identified yet. History supports this. The Spanish flu of 1918, HIV, SARS, Ebola outbreaks, COVID-19. Each one emerged from an unknown source and caught the global health system unprepared. Disease X is the WHO's acknowledgement that the next one is not a question of if, it is a question of when. Ana Maria Henao Restrepo, the physician leading the R&D blueprint at the WHO Emergencies Program, described it directly in a 2024 interview. There is no virus or bacteria circulating right now that is called Disease X and is causing disease. We are preparing for the future. The WHO has invited hundreds of scientists to identify viruses and bacteria with pandemic potential. Their estimate: there are thousands of them. Disease X is the name for whichever one gets there first. COVID-19 was a Disease X event. Before it was identified as SARS-CoV-2, it was exactly the kind of unknown pathogen the concept was designed to describe. It emerged. It spread. And the world spent the first critical months scrambling because the infrastructure to respond wasn't ready. The entire Disease X framework exists because of what COVID exposed. In the aftermath of COVID, a coalition called CEPI, the Coalition for Epidemic Preparedness Innovations, launched what they call the 100 Days Mission. The goal: develop a safe, effective, deployable vaccine for any new Disease X pathogen within 100 days of identifying it. That's just over 3 months, from the moment an unknown disease is recognized to a vaccine being ready for emergency authorization and mass manufacturing. For context, the fastest vaccine ever developed before COVID took 4 years. The COVID vaccines, which were considered a scientific miracle of speed, took approximately 11 months. CEPI's own analysis found that if effective COVID-19 vaccines had been available within 100 days of the outbreak being identified, approximately 8 million lives could have been saved in that first wave alone. The technology making this possible is the mRNA platform, the same platform used in the Pfizer and Moderna COVID vaccines. And here is where it gets complicated. The mRNA platform was not developed for COVID. It was developed years before COVID existed, specifically as a Disease X response technology. Researchers at Moderna and BioNTech had been working on it since the early 2010s. By 2019, months before COVID emerged, the platform was functionally complete. It was sitting ready. When COVID hit, the vaccine wasn't built from scratch. The platform was already there. Researchers simply loaded a new set of genetic instructions for the new pathogen. The speed wasn't a miracle. It was a demonstration of a technology that had been prepared in advance for exactly this kind of event. The question that raises: what else is already on the shelf? In May 2025, the World Health Assembly adopted what it described as the most significant global health treaty since the WHO was founded, the Pandemic Agreement. The treaty establishes international coordination frameworks for detecting and responding to the next Disease X event. It sets rules for equitable vaccine distribution. It creates early warning systems and mandatory reporting protocols for member nations. It gives the WHO new powers to coordinate global response, including access to pathogen samples and real-time surveillance data from member countries. 54 nations signed it. The signing was described as historic. One nation was not in the room. On January 20, 2025, the first day of his second term, President Trump signed an executive order formally initiating the United States withdrawal from the World Health Organization. The withdrawal was completed. The U.S. flag was removed from outside WHO headquarters in Geneva. The U.S. is not party to the Pandemic Agreement. It has no formal role in the early warning system. It has no access to the coordinated surveillance network. It has no seat at the table for the response framework. The official justification was the WHO's handling of COVID-19, specifically the early timeline of information sharing with China, and the delayed declaration of a public health emergency of international concern. What that means practically: the world's largest economy, the country that funds the most global health research, the nation that houses the CDC, the primary global disease surveillance agency, has opted out of the coordinated system designed to detect and respond to the next pandemic. Johns Hopkins public health researchers describe the consequences directly. U.S. withdrawal disrupts global disease surveillance, removes the largest single funder from the early warning network, and creates a gap in the monitoring system at the exact moment that monitoring system is being rebuilt specifically to catch disease X before it spreads. If a blank space on the WHO's priority disease list, with vaccines already in development and a global treaty already signed, keeps you in your seat, subscribe. Things that shouldn't exist goes this deep every single week. Disease X is a placeholder, but scientists are not waiting passively. In January 2026, scientists at the University of Florida identified 2 specific pathogens they described as quietly flying under the radar, with significant pandemic potential: influenza D virus and canine coronavirus. Neither has a widely available vaccine. Both have demonstrated the ability to jump between species. In December 2025, CEPI launched a new program to develop an mRNA vaccine against a tick-borne virus, causing fatal hemorrhagic fever across Asia, severe fever with thrombocytopenia syndrome. Mortality rate between 12 and 30%. Currently, no approved vaccine exists. In February 2026, the WHO marked the 6-year anniversary of COVID's global alarm by asking a direct question in its own official communications: is the world better prepared for the next pandemic? Their answer was carefully worded. Progress has been made. Significant gaps remain. The gaps they identified: fragmented surveillance systems, inequitable access to countermeasures, and insufficient investment in the platform technologies that would allow rapid vaccine development. All 3 existed before COVID. All 3 still exist now. Here is what we actually know. The WHO has officially recognized since 2018 that a pandemic from an unknown pathogen is not a theoretical risk. It is a scheduled event in the sense that institutions are building infrastructure to respond to it. Treaties have been signed. Platforms have been built. Simulation exercises are running right now in Korea, in Europe, across the developed world. The mRNA platform can generate a vaccine for a pathogen it has never seen in weeks, if the pathogen is identified and sequenced quickly enough. The 100 Days mission exists to make that identification and sequencing happen fast enough to matter. The U.S., which funds more global health research than any other nation, has removed itself from the coordinated detection system at the exact moment that system is being rebuilt. And the HHS, the U.S. Department of Health and Human Services, announced in August 2025 a coordinated scale-down of mRNA vaccine development programs. The platform that makes 100-day vaccines possible is being deliberately wound down by the country that helped build it. The institutions preparing for Disease X are doing exactly what they say they're doing: building a response system for an unknown future threat. That is responsible public health planning. The part that doesn't sit cleanly is this: they are more certain it's coming than they are able to say publicly. The infrastructure being built, the treaties, the platforms, the simulation exercises, the 100-day timelines, is not the infrastructure of an institution that thinks a pandemic might happen. It is the infrastructure of an institution that knows one will. A placeholder on the WHO priority disease list. A vaccine platform built before the last pandemic hit. A global treaty signed by 54 nations, with one conspicuous absence. A 100-day countdown that starts the moment something new is identified. Disease X doesn't have a name yet, but every major health institution on Earth is preparing for it like it has a date. Drop a comment. Do you think this is responsible preparation, or does the certainty of the people building the response system tell you something they're not saying out loud? Next week on Things That Shouldn't Exist, a radio telescope in Ohio picked up a 72-second signal from deep space in 1977 that matched every theoretical characteristic of an extraterrestrial transmission. It has never been detected again. The WOW signal. Subscribe. I'll see you there.